My name's Dr. Rekha Kumar. I'm an endocrinologist and obesity medicine specialist. In regards to my jobs, I'm an associate professor of clinical medicine at Weill Cornell, and I'm also the chief medical officer of Found Health, which is a digital health company that focuses on comprehensive weight care. So I've always been interested in fitness, nutrition, and metabolism, and unlike many physicians who probably choose what they're going to do later on in their medical education, I actually became a clinician and went to medical school in order to help people with their metabolic health. I knew I wanted to be an endocrinologist probably when I was 16. I loved muscle metabolism, sports, nutrition, fitness. I was a gymnast growing up, and that led me to understand health before many people did. I got deeper and deeper into the science of fitness and metabolism, which led me to medicine and endocrinology. At that point, I thought, well, now I'll go into practice. And literally the year I was finishing my training, the American Board of Obesity Medicine was established, and a new field of medicine was being created as I was entering the job market. I was asked to be the endocrinologist at a place called the Comprehensive Weight Control Center at Weill Cornell. It was going to be a new center. They needed an endocrinologist to manage hormone issues, type 2 diabetes. And I thought, sure, I'll try this. And on my way, I learned obesity medicine and became board certified and became the first medical director of the American Board of Obesity Medicine. My job there was to write the credentialing exam for physicians who chose to become board certified in the field. And it gave me a chance to step back from clinical medicine and really look at all of the science in the field of obesity medicine objectively in order to test physicians and write questions that were fair and balanced no matter where people were practicing. The recent advancements in the use of pharmacotherapy for obesity, particularly the attention on GLP-1s, has really increased people's attention to the biology of body weight regulation. Even clinicians, physicians, and scientists who continued to believe that there was a willpower issue with patients, physicians that occasionally continued to not want to write these prescriptions because they really felt that this was a lifestyle choice. What the recent attention to the new medicines has allowed for is really more people to appreciate, value, and accept the fact that there is strong science and lack of willpower control over body weight. Obesity is a heterogeneous disease, and care needs to be individualized. I think we're just touching the surface of what degree of individualization and personalization proper obesity care requires. In other disease states, such as immunology, cancer, we're able to test genetics, know exactly what drug to use. We're not there yet in obesity, but we're starting to appreciate that different mechanisms of action of different drugs are necessary to treat individuals. Likely some intricate combination will be needed for each person, but we are not yet there with knowing what that perfect cocktail is for each person, but that's my hope for the future. The biggest gaps are probably in looking at diverse populations. Just like in many other medical fields of research, there's lack of data in people of certain ethnic backgrounds, minorities, women, menopausal women, people in different stages of life. So I think we really need to study diverse populations and what factors impact cardiometabolic risk at different stages of life in diverse populations. Trends I'm seeing in my own practice, plus also globally, are more of an interest in pediatric obesity and addressing metabolic disease earlier in life, especially after the COVID pandemic. We saw children that were sedentary start to develop type 2 diabetes and obesity at younger ages than we previously saw all over the world because of quarantines and lack of ability to go out. So I do think there's more of an interest in treating people younger. What I'm seeing in the United States, particularly in the consumer health area, is even for people that aren't taking medicine for their weight or aren't on a GLP-1, there's so much GLP-1 curious consumer interest, whether that is related to supplements or food products or powders, things that could perhaps naturally boost not only GLP-1, but fullness hormones or supplements that may be GLP-1 companions or vitamins. So in addition to the innovation in the pharmacologic market for anti-obesity therapy and metabolic health, there seems to be a parallel universe of consumer demand for vitamins and minerals and supplements that could supplement or companion someone's journey on all of these meds. I think as we've seen people do well on new anti-obesity medications and GLP-1s, we've definitely seen the meds fall into hands of people that don't typically qualify. Some of it for vanity, which of course in the medical field that's concerned us because we've not been able to get medicine in the hands of patients with diabetes and severe obesity. But interestingly, I think that real-world evidence is where we started to learn that these medicines reduced the desire to drink alcohol, that perhaps there was improvement in certain inflammatory conditions, that other cravings and compulsive behaviors improved. I think that there have been scenarios recently that have occurred due to the widespread use and sometimes even not appropriate use, but because we have so many numbers of people using these meds, we've gotten additional information that we haven't expected to see. One of the challenges with taking care of patients in the long term for their weight management is the concept of metabolic adaptation. What this means is that when anybody loses weight, the body engages mechanisms to try to make them regain the weight or to defend their highest fat mass. This is a mechanism of survival or an adaptation for survival. It is to protect humans from starvation. Although our environment has changed tremendously in the past hundreds of years, our biology hasn't changed much, and humans are adapted for survival. Metabolic adaptation happens when any human being or animal loses weight, their metabolism slows, their hunger hormones go up, their fullness hormones go down, and their body is put in a position to favor weight regain. Some of the most critical biological factors in understanding obesity is understanding the hormonal regulation of body weight, or the neurohormonal regulation of body weight. And this was relatively new information just as recent as 30 years ago with the discovery of leptin, a hormone that is made in fat cells and signals fullness to the brain. Prior to that, we really just thought the fat cell was a depot for fat, that it was just there to keep us warm, keep us plump. We had no idea that it was metabolically active. What we learned with the discovery of leptin was not only is the fat cell an endocrine organ, but it's in communication with the brain and other parts of the body, making not only fat storage, metabolism, but appetite control under biological control. Since the discovery of leptin, we've learned that there are so many hormones that are circulated throughout the body that work peripherally and centrally to help not only control appetite and body weight, but are involved in cardiometabolic risk. My hope is that there will be more pharmacologic interventions to fight metabolic adaptation to allow people to move further along in their weight journey. Treating metabolic health and obesity is really not just about the number on the scale, or really not about the number on the scale at all, but rather about healthy body composition and avoidance and resolution of weight-related comorbidities. So our goal isn't to achieve a certain number, but rather to achieve a point in your health where your blood pressure, cholesterol, mobility, all of those things, blood sugar control, are at a place to improve your longevity and reduce your cardiovascular morbidity and mortality. It's always interesting to look at clinical trial data versus real-world data. Of course, clinical trials are done under very controlled settings. Patients are often required to meet certain strict criteria in order to enter these trials, whether that is a certain number of comorbidities, a severity of obesity, and dosing is pushed to the desired treatment therapeutic dose. And so it is different than the real world, whereas we don't always push doses high up. We may treat someone that falls outside that typical range because they are high risk for metabolic disease. What we're actually learning now is that there's so many people that could benefit from treating their weight, treating their metabolism, that actually fall outside of that clinical trial zone. So those really high BMIs, those really sick patients, we actually probably could do a lot with prevention when we look at real world data, who's actually taking these medicines. Yes, some of it is off-label, but we are seeing that we likely could do a lot in the preventative health space, and we're really gaining that information from real-world experience. What do I see happening in the next 10 years in the field of metabolism and obesity? It would probably help to talk about what I saw 10 years ago, around the time I finished my training and started my career. Probably a year into practicing, 2 drugs were approved, Qsymia and Belviq. One has already been taken off the market, and the other never really had as amazing uptake amongst clinicians and patients that we expected. And so for the past 10 years, I would say, although the science of obesity has evolved, the clinical practice really didn't very much until GLP-1s. And now we're seeing a huge uptick in benefits, health outcomes, efficacy data for weight loss, patients that want to be on them, clinicians that want to learn about it. So where I see the future going is that it is acceptable to seek care for this type of condition, for your metabolism, for your weight, for your cardiometabolic risk. I also hope that we have more information on genetics of individuals and precision medicine. I'm super excited to see a future where precision nutrition is part of how we treat patients for their metabolic health. 10 years ago, people would see me as the last resort. When they came to me, they often were brought in by a friend, a relative, a parent, or really pushed by another clinician, perhaps a cardiologist or a primary care doctor, to see me. And they felt that if I couldn't help them, then nothing else would, and they would definitely have to get bariatric surgery. And many times they didn't qualify for bariatric surgery. That feeling of complete last resort is not the way patients come to me today. They actually come in more hopeful because they've seen people do well on the more modern medications. When I think of the different biological mechanisms that could be responsible for someone's obesity, I think of all of the pathways that we know of that are involved in body weight control. And everyone, to a certain degree, regulates their body weight slightly differently. So in the condition of obesity, it's not one mechanism or one pathway that's not functioning normally in everybody. The GLP-1/incretin pathway has gotten tremendous attention in the past several years due to the recent drug developments in this area of medicines like semaglutide and tirzepatide. There are still patients we see in practice that don't respond, that are subpar responders to GLP-1s, or actually even gain weight. Something that's come to our attention in the past several months to year is the muscle loss with GLP-1s. Whether people exercise, try to maintain their protein intake, there are increasing concerns about loss of lean muscle mass. And what that means to me, thinking about the biology of obesity, is that there's some other pathway in the body involved in body weight regulation and appetite that might not be working properly. The mechanisms that I see showing a lot of promise for the future are mechanisms that target fat as well as muscle, as well as appetite. Maybe that is related to the endocannabinoid system, such as CB1. I think the role of CB1 inhibition in this whole landscape of pharmacologic targets is that it really could allow a population of patients that we haven't yet been able to treat or to target their hunger. It may be a mechanism that allows us to treat more people that haven't yet felt like anything has worked for them. I'm most excited to see potential combination therapy with different mechanisms of action. So using GLP-1s, GLP-1 and GIP dual agonists in addition to the CB1 inhibition pathway to see if we can achieve better outcomes in more patients. I think combination pharmacotherapy, thinking about different pathways of body weight regulation, peripheral pathways, in addition to central pathways, will be key to the future comprehensive treatment of patients with obesity. In addition to central mechanisms, it's important to think about peripheral mechanisms. Sometimes we even can get a lot of use out of older medicines, such as phentermine, working on the sympathomimetic pathways, metformin, working on glucose uptake and insulin resistance. So there are so many areas of the body peripherally that we can still target to help people manage their metabolism, weight, and appetite. One of the biggest challenges in taking care of patients that struggle with obesity, metabolism, and their metabolic health is all the biases that are embedded in our culture related to weight. And that's not only a societal bias with a preference towards thinness, but clinician bias on, a lack of education that we've all experienced through our training and not learning about the biological pathways involved in metabolism, and even patients' own biases about themselves, which makes it very hard to treat patients who are already judging themselves, thinking that they've failed. One of the ways to overcome these biases is to really keep the science at the center. When I meet a patient, in the first several minutes, I really try to take their story and put it in the context of science and explain to them what is in their control and what is not in their control. And I tell them the numbers, that 60 to 80% of their body weight is not under their control. That immediately makes them feel more comfortable and not judged, and that whatever we're about to do is not related to something being their fault. The issue of adherence and anti-obesity medication is a particularly interesting one. It's always been a challenge to explain to people that if medicine helps their weight, that they may need to be on it for the long term. That doesn't mean they can never, ever take a break from it, or that the second they stop it, they regain the weight. But it's important to frame metabolic health and obesity as a chronic condition. Once your body knows how to regain the weight, it has a tendency to go that way. So somebody can pause medicine. They might notice over a period of time that they become more hungry. People that abruptly stop medicine do gain weight or regain approximately 2/3 of their weight in the first year, which is the clinical trial answer of what happens when you stop anti-obesity medication. I think the reason adherence is poor currently, looking at the GLP-1 data, particularly that study that came out of Blue Cross that really concerned payers, showing that most people stop their GLP-1 within a few months, is because there's so much liberal prescribing of GLP-1 without comprehensive support right now. When I learned that data showed that most people came off their meds within a few months, I was thinking, well, in my practice, I never see this happen. People always stay on their medicine, or if they're going to stop, they come in and have a conversation. And I think the reason for that is that the support required for continued adherence is so hands-on. That not only means continuing to write a prescription, it means continuing to counsel a patient on what this journey looks like, meaning when their weight starts to plateau, explaining to them what is going on in their body. That doesn't mean the medicine stopped working. It doesn't mean they're not doing their job, but that's metabolic adaptation. I'll often hear patients say, I'm not losing weight anymore, when they've lost 20% of their body weight, and they say, I'm gonna stop the medicine. And I say, no, don't do that. The medicine is working. If it weren't working, you would have regained all the weight. The problem is that most clinicians don't understand this information. So I'll occasionally see a patient that was put on a medication by their primary care doctor. Perhaps they lost 20 pounds and their primary care doctor said, I'm going to stop the medicine because you reached your goal. And then they regain the weight. There's such a demand for patients to ask their providers for these prescriptions. People are writing them now because of increased awareness of the safety and health outcomes, but not everyone prescribing them knows how to comprehensively manage the medical condition and the patient. I do think adherence would be better if clinicians and patients could have more knowledge on what the long-term journey looks like. This is a field of medicine and a medical condition that requires long-term follow-up with a clinician and a patient, regardless of how well a patient does. Even if somebody loses weight, achieves good health, and is at their ideal body weight, there's no patient that I will go more than 6 months without seeing. The reason for that is that obesity is such a complex interaction between someone's biology, their hormone health, their environment, the aging process, that small things that change despite adherence to medicine and lifestyle can impact their weight journey. Currently, we're in a time where we are actually seeing medicines that are extremely effective. People are losing weight, keeping it off, achieving better health. But unfortunately, these medicines are extremely expensive and difficult to access. As the months and years have gone on, we've actually seen a reduction in coverage of these medications due to concerns about long-term costs, not only by insurers, but by employers as well. One of the ways that we can control these costs are likely by providing comprehensive support to our patients and making weight care more engaging for people. So not just writing a prescription and saying, see you in 6 months, but making sure that in between doctor's visits, there's some type of contact. It could be even asynchronous contact through telehealth. There are many ways to engage a patient. There are communities of people that can help each other online. I know that there are support groups of people that take certain medicines. So in addition to the patient-doctor relationship, continued prescriptions, I also think that people that are receiving treatment for their weight can help each other through certain online platforms. What we're seeing now is a desire to innovate and educate and understand new mechanisms of drug targets that can hopefully help people that we haven't been able to help before. And we're, I think, seeing a group of people become involved in the development of knowledge, evidence, and therapeutics that previously weren't. And I think that this is great for patients and our population. Sometimes what concerns me and keeps me up at night about these new medicines and the future of metabolic care is whether this will just all be reduced to prescriptions. Is there a field of medicine here, or is this just going to disappear into another just set of drugs that people prescribe and there's no comprehensive wraparound appreciation for all of the things that led us here? Is obesity medicine a sustainable field when some people believe that these drugs can just cure everything? So all of the things we learned to become board certified in this field and treat patients really well. So what we learned about motivational interviewing, how do you appropriately start a conversation about obesity and metabolic health in patients that have previously been stigmatized, learning about various nutrition interventions, which ones show evidence, which ones don't, understanding muscle metabolism, and truly creating a body of content that qualifies as relevant to the field of obesity medicine. In some ways, I feel like we're headed in the right direction. In other ways, I'm concerned that we're not always getting to root cause by ignoring the issues related to rapid urbanization and what that does to our physical activity and food consumption. Although I'm so impressed and excited about the drug development, I would like to pay equal attention to the lifestyle factors. If I could ask people to do things differently, being that obesity is complex and heterogeneous, I would have to say it's not just about the medicines, it's not just about exercise, but it's also about our food supply in the United States. There were tremendous changes in our food supply in the 1970s, which really tracks with when the obesity epidemic started to rise. We cannot blame the entire obesity epidemic on food consumption or food quality. There are also strong genetic factors, but I think in order for us to properly treat this global epidemic of obesity, that we really need to treat all of the pieces, meaning underlying genetic pinnings, hormonal, exercise factors, public health factors, and urban planning, allowing people to walk around their cities safely, exert more energy during the day, especially with the use of technology and more energy-saving devices or energy-sparing devices. I think we need to encourage people to burn more calories built into their life, which technology has done the opposite for us. I do think there probably needs to be some change in food policy. It really does feel that when somebody moves to the United States from a different country, there tends to be complaints despite following what they think is the exact same diet. Why are they gaining weight? Likely something related to hormones and additives. And I really think that there's some responsibility there for America to improve our food supply. I actually live this and breathe it and do it all day, not just when I'm at work. It's my home life too. It's such a priority for me, myself, but also for me to get the people around me, family, friends, patients, to understand how good it feels to be healthy the right way, that I would love for the people in charge of our policies and our laws to put the right changes in place. It might have to be very significant. It might mean that the way we pay for healthcare needs to be different. It might mean the way we get our food is different. It might mean the number of hours a week we expect ourselves to work has to be different to pay attention to our health properly. I think we need an overhaul not only of our policies related to healthcare, but also our lifestyle.